Hello, my name is Erwin Lowe, and I'm the Group Chief Medical Officer for St. Vincent's Health Australia. I'm here to talk to you about variation in clinical practice. It's about reducing variation and increasing innovation in the health service. So we know that the literature tells us that improving quality and patient safety can be done by minimizing unnecessary variation. And this has been replicated through multiple research studies. We know that reports have been published on this topic, and the Australian Commission on Safety and Quality in Healthcare have released a guide for the review of clinical variation in healthcare, which is what actually this conference is all about. So how does a hospital network like St. Vincent's Health Australia monitor variation in order to address them? So there are a few ways. So the major way that most hospitals monitor data is through KPI tracking. That these are key performance indicators, clinical indicators, and these tend to be automated, prospectively collected data, and it's useful. So things like medication errors, falls, pressure injuries are collected this way. This includes hospital-acquired infections as well. Then we can do audits as well, right? So audits are usually retrospective. They're more manual. It requires people with checklists to tick off, to ask questions or observe things. So we can do bedside audits, observational audits, or even paper record audits. But they're helpful, again, to identify variation. We can actually do deep dives too. So many hospitals identify high-risk areas and then do a deep dive investigation to ensure that there is no variation. And last but not least, there are clinical registries. There are different medical colleges and universities that collect registries for example, cardiothoracic surgery, emergency medicine, orthopedics. We know a good example of this in Victoria is the Victorian Audit of Surgical Mortality, or VASM. So these are central registries that collect data from different hospital units. They provide then back to the hospital report showing if there were any variation comparing the hospital with state or national peers. And they are useful as well. So I'm going to give you examples of how St. Vincent's Health Australia uses each of these methods to look at variation. So the first that we're going to look at is KPIs. So CLABSI, or central line associated bloodstream infections, is a very common clinical indicator that is monitored by hospitals. So for St. Vincent's, in 2018, we picked up a variation. We found, if you look at the graph, you can see, actually, you should see two lines, but you can only see one. And that's because St. Vincent's Hospital in Melbourne, the public hospital in Melbourne, had multiple instances of CLABSI infections in the ICU. St. Vincent's Hospital in Sydney, on the other hand, has not had a single CLABSI infection since 2017, and this record still holds. So what we did is we picked up the variation, and clearly then we needed to look into it. And the bottom is just to show you the breakdown between the different hospitals as part of the Melbourne and Sydney networks. So what we found was that there was variation in how people were using PACS, how they were actually putting in the lines. And we came up with pathways and guidelines to reduce that and to fix that. We found out that people weren't washing their hands properly. They weren't following the 6 moments. In fact, the second moment was the issue. We picked that out through an audit. And so we provided training. And last but not least, there was very poor documentation in relation to putting in central lines. And we put in processes to fix that as well. And as you can see here, that was in 2018. You can see that in 2019, in fact, the Melbourne Public Hospital went back to 0. So we essentially fixed the problem. So this is how KPIs can help to minimize variation. The other thing that we do have in our repertoire of things that we can look at is audits. So we use what we call the MAS system, which is a database that we centrally manage at the group level nationally, but it's being used by our hospitals throughout the country. And an example that I'm going to share is standard for audits. So when it comes to audits, you can do bedside audits, you can do medical record audits, you can do observational audits. There are many different types. But with medication safety, you can see that we do a whole suite of audits on a regular basis. And I'm going to just highlight the one around the percentage of patients whose identity was checked before receiving medication. You can see that St. Vincent's as a whole nationally, we seem to do quite well, 89%. But if you break that down, this is a particular hospital and particular wards. You can see actually, even though the consolidated number is 89%, you can see quite a bit of variation between the wards. In particular, the birthing suite at 50% and the maternity postnatal at 70%. So here, we picked up that the maternity wards in that particular facility had an issue with checking people's identity before they are prescribed or before they administered medications. So that's how we use audit. But then we at St. Vincent's implemented this deep dive program. So it's essentially a deep dive audit or review of high-risk areas. So we call it SCARP, or St. Vincent's Clinical Assurance and Reliability Program. And we looked at areas where we felt we should look at in terms of making sure there was no variation. So we looked at chest pain, acute coronary syndrome. We did it as a pilot initially over 12 weeks. And I'm just going to show you some of the data that we collected. So if we compare the Sydney Public Hospital with the Melbourne Public Hospital, again, because those are our two largest sites, and you can see in terms of demographics and people turning up, they were basically similar, about 50 people turning up a week compared to in Melbourne compared to 46 in Sydney. You can see then in terms of the rest of the demographics, we're going to detail the breakdown between female and male. They were all very, very similar where they were coming from. And then if you look at emergency presentations, again, quite similar, although interestingly enough, the presentations for chest pain peaked in Sydney on Monday, but peaked in Melbourne on Tuesday. And then also in Sydney, they had roughly twice the number of category 1s as well compared to Melbourne. Then if you then look at the time of presentation and how they presented, time of presentation was basically the same, but there were nearly half the patients in Sydney turned up with chest pain through public transport, while only 10% of that was in Melbourne. So interesting variation. What did we learn through this deep dive of chest pain? We found out that 100% of our patients received treatment within 12 hours, so that's fantastic. We found out that 83% of them had an ECG within 10 minutes, so not as great. And then 63% got door to balloon time. The door to balloon time for 63% was within 90 minutes, which is not best practice. So we kind of identified those issues. So what did we find and then what did we do? So this is what we did. Through the findings, through looking at what we did, we found out that documentation in terms of what was going on was poor. So we provided training, beefed up our policies around that. We found out that there were different pathways being used, and we consolidated that at a national level. We found out that documentation of ECG changes was poor, so we fixed that as well. Risk stratification wasn't very good as well, so it wasn't poorly documented, and we provided training around it. And again, last but not least, the care plans that were being used was not documented properly, so we fixed that. One thing that we did find out of the deep dive was that the cath lab and the emergency department was siloed. They weren't talking to one another and it was poor coordination. So we basically broke down the silos and got them together to come up with joint pathways to manage chest pain. The other thing that we did as a deep dive was stroke. And again, this is looking at variation to compare our hospitals with national and international data. So in terms of time critical stroke, we know that nationally, 36% of patients reach hospital within 4.5 hours. The good news for us is that 100% of both our hospitals and our private hospitals as well got that timeline. Then we know that in terms of use of thrombolysis, 7% in 2015, 30% in 2017. We found out that Sydney was above the target, but Melbourne was kind of just below. And then in terms of ensuring the thrombolysis given in hospital within an hour, Australia actually as a country falls behind the US and the UK. In our hospitals, public hospitals in particular, we're actually above the Australian targets, so that was pleasing to find out. We know that 77% nationally of patients get care in a stroke unit. We found out actually that in Sydney, our public hospitals and our private hospitals get treatment in a stroke unit, but only half our patients in Melbourne got that. So that was a variation there. 35% of patients nationally did not receive a discharge plan. We found out that, in fact, and this is a reverse number, most of our patients did get a discharge plan, which is very pleasing for us to know. 33% are discharged without any prevention medication, but most of our patients did get that as well, which is, again, good for us to know. So what did we learn and what did we do? So we know that in Sydney, we did actually have a dedicated stroke unit in both our public and private hospitals, but this wasn't the case in our Melbourne Public Hospital. They had a stroke care team, but not a dedicated stroke unit. So what did we do? We created one in our Melbourne Public Hospital. We also found out that in our Melbourne Public Hospital, they didn't have a cold stroke alert. We created that as well. So we got the Melbourne Hospital in line with our Sydney Hospital, and our results have improved since then. Now, the last thing that I want to touch on is registries. So I'm going to use the example of the VASM registry, the Victorian Audit of Surgical Mortality. We got a report recently, and we got a report, and because VASM is Victorian, I can only really look at our Victorian hospital. So I look at the Melbourne Public Hospital and the Melbourne Private Hospital that for instance run. And I'm not going to go into detail, but as you can see, in one sense, we can't really compare our public hospital with the private directly because our Melbourne Public Hospital is a tertiary academic hospital. Our private hospital in Melbourne is actually quite a small hospital, but we can actually compare them with the peers. So the good thing about the VASM report is that we get our peer state and national hospitals so that we can compare apples with apples. I'm not going to go into detail in terms of each of these, but you can see that there is some variation comparing ourselves with our peers. But here is a good example of how we can use this data. You can see that in terms of prophylaxis use against DVTs, our public hospital had an issue in the past couple of years, but they've fixed that. Similarly, in our private hospital, we had an issue as well, but that was identified through this registry data. Consulting in hospital is something that has a good chief medical officer I'm interested in. And as you can see, we got consultants in our tiers in both public and private, which is very pleasing to see. Unplanned admissions to ICU seems to be an issue in our private Melbourne hospital in the past few years. That was something that we need to look at. And then fluid balance. So this is interesting information. It's in the public hospital seemed to be, and in the private hospital seemed to have been an issue in the past. But again, emerging as an issue again in our public hospital in the past financial year. So what did we learn from this kind of registry data? One thing we learned is that we had an issue with our venous thromboprophylaxis guidelines and practice. So this is something that we identified and we dealt with. Fluid balance is the other issue that we identified. And again, both our public and private hospitals are looking into that. And then how we use critical care. What did we find out that we did well? Consultant in theater looks as though we have that and we do that quite well. And it looks as actually from the VASM data that we actually identify our deteriorating patient early so that we have low complication rates as well. So as you can see, a hospital network like ours at St. Vincent's, we can use KPIs, we can use audits, we can use deep dives and registry data to monitor for variation, identify issues, and then come up with recommendations to fix it, and then we can evaluate what we've done. The last thing I'm going to talk about really is the tension between reducing variation and increasing innovation, which is the title of my talk. So how do we do that, right? So on the one hand, innovation is about disruption. It's about making step change and creating a paradigm shift within your hospital. Whereas reducing variation actually is the opposite. It's about standardization. It's about telling people, follow guidelines, don't vary. Well, actually, if you look at the literature, they tell you that they go hand in hand. So innovation and reducing variation are two sides to the one coin. There is no question that reducing variation improves quality and safety and care because the literature tells you that. So that's the kind of new standard line that you can see on the graph in front of you. But innovation is when you come up with a new technique. So when research studies tell you this is the new drug that you need to use now because the old drug has been superseded, or this is a new practice because we have done research to show this is a new model of care, or through innovation, through an invention, someone has figured out this is a better way of doing something, then you make that the new standard. So then what happens is you tell everyone else, look, this is the new guideline, this is a new policy. Everyone now has to reduce variation to follow this new standard. So that's where the graph shows you that innovation goes up and then new standards. The Kaizen, this is the lean methodology, the lean terminology that people use. You want to reduce variation and then until the next innovation, and then you innovate, and then you kind of reduce variation up to the new standard. Does that make sense? So hopefully you can understand that, in fact, they go hand in hand, and you do need to have both processes going on at the same time. So I'm going to stop here. I'm happy to take questions. Feel free to email me at any time, and thank you for listening.